Hello everybody. Welcome to number 1 Doctor channel. Today video is about abdominal wall hernias, which is part of our playlist called Short Medical Notes, in which we will have short videos about important topic in medicine. But please do not forget to like and share our videos and subscribe to our YouTube channel number 1 Doctor, and join our social media accounts in the links below each video. Our aim is to share the correct medical knowledge for all for free. Share and be shared. Today we will talk about abdominal wall hernias. Abdominal wall hernias are common surgical problems encountered in all levels of healthcare facilities. Adequate knowledge to reach to the correct diagnosis and appropriate management plan help the care provider to prevent serious complications which could be fatal. Definitions. Hernia is a protrusion of a viscus through an opening in the wall of the cavity. Important terminologies. Hernial sac is an outpouch of the peritoneum. It has 4 parts: mouth, neck, body and fundus. Content is a viscus or any other organ inside a sac. It can be small bowel and omentum, the commonest, large bowel appendix. The bladder. Reducible hernia when the protruded viscus can be returned back to the abdomen. Irreducible hernia when the contents can't be returned back. Obstructed hernia, the content of the hernia intestine is occluded but no impairment of vascular supply. Strangulated hernia when the vascularity of protruded viscus is impaired. Richter's hernia when only one side of the wall of the intestine is herniated. Here strangulation of the bowel can occur without intestinal obstruction. Sliding hernia when an extraperitoneal structure form part of the wall of the sac. Risk factors for abdominal wall hernia development. Increased intra-abdominal pressure resulting from chronic cough, straining at urination or defecation, heavy weight lifting, abdominal distension, weakened abdominal wall, advanced age, malnutrition, congenital defect PPV, trauma or surgery. Clinical features. History. Lump which varies in size. Pain, local aching, discomfort. Factors predisposing to increased intra-abdominal pressure. Symptoms of intestinal obstruction or strangulation. Physical examination. Patient is examined in standing and lying position. Lump reducible, cough impulse with bowel sound. May be reduced when patient is lying and increases in size when patient is coughing or straining. Relation of the lump with the common references: pubic tubercle, inguinal ligament. Signs of obstruction: tense, tender, irreducible with absent cough impulse. Signs of strangulation: more tenderness, with warm indurated, and inflamed overlying skin. Investigation. Hernia is a clinical diagnosis and investigation is rarely needed. Complications of abdominal wall hernias: 1. Irreducibility. 2. Obstruction. 3. Strangulation is a surgical emergency. Risk of obstruction and strangulation is very high in femoral hernia, periumbilical hernia and indirect inguinal hernia with narrow neck. Principles of management. Spontaneous resolution is unlikely. The risks of irreducibility, obstruction and strangulation increase with time, so surgical intervention is needed in most cases. Surgical treatment for abdominal wall hernias: 1. Herniotomy, removal of the sac and closure of the neck, done only in infants and children. 2. Herniorrhaphy, herniotomy and repair of the wall to prevent recurrence. Obstruction and strangulation. This is one of the causes of intestinal obstruction: acute abdomen. Therefore, one shouldn't forget to examine the hernial sites during evaluation of the patient with intestinal obstruction. Treatment options. Non-operative treatment. Gentle reduction taxis can be indicated in obstructed hernia in infants but not advisable in adults due to the risk of mass reduction. Procedure taxis. Put patient in head down position. Sedative is given. Gentle manipulation to reduce the hernia. NB. No place for vigorous manipulation and be ready to stop the procedure when any difficulty arises. Urgent surgery is indicated in great majority of obstructed hernia and all strangulated hernia. Specific types of hernia. Anatomy of inguinal and femoral canal. Inguinal canal boundaries. Anteriorly, external oblique aponeurosis. Posteriorly, fascia transversalis. Inferiorly, inguinal ligament. Superiorly, conjoined tendon and internal oblique muscle. This canal runs in antero-inferior direction from internal to external ring. The internal ring lies 2 cm above and 2 cm medial to mid-inguinal ligament. The external ring lies just above the pubic crest and tubercle. Contents of inguinal canal. In male, spermatic vessels, vas deferens, ilioinguinal nerve, genitofemoral nerve. In female, round ligament. Anatomy of femoral canal. Is a narrow rigid space bounded by inguinal ligament, superiorly. Pectineal part of inguinal ligament posterior. Lacuna part of inguinal ligament medially, Femoral vein laterally. The narrow rigid space makes this types of hernia more prone to obstruction and strangulation. Inguinal hernia. Accounts for 80% of all external abdominal wall hernia. Commonest is all ages and sexes. 20x more common is males than women. More common on right side classification. 1. Indirect type, passes through internal inguinal ring along the inguinal canal. May extend down to the scrotum. 2. Direct type, bulges through the post wall of inguinal canal. Indirect inguinal hernia 60 on right, 40 left-hand side and 20 bilateral. Due to congenital defect or potential defect which is the remnant of processus vaginalis. 20 times more common in men. Direct inguinal hernia. Due to wear and tear associated with advanced age and increased intra-abdominal pressure. Femoral hernia. Acquired downward protrusion of intestinal contents into the femoral canal. 4 times more common in females middle-aged multiparous. Rare in children. Clinical features. History. Elderly or middle-aged woman with thin body build. Lump on anterior and upper thigh. May present with complaints associated with obstruction or strangulation. Physical examination. Small lump on lower groin, lateral and below pubic tubercle. Reducible irreducibility. Bowel sound cough impulse usually absent. Management. Surgical repair without delay. Umbilical paraumbilical hernia. Umbilicus is one of the weak sites of the abdomen. A hernia can occur at this potential site. Risk factors. Female sex. Multiple parities. Obesity. Ascites. Complications. Obstruction. Strangulation. Rupture. Treatment. Expectant, spontaneous closure is expected in 80 cases of umbilical hernia in under 5 children. Surgery, beyond 5 years. Incisional hernia. Risk factors. Wound infection. Poor surgical technique, improper facial repair. Chronic cough or straining. Obesity. Clinical features. Risk of obstruction and strangulation is very rare. Local discomfort. Cosmetic problems. Difficulties with micturition and bowel movement when very large. Treatment. Herniaplasty. Thanks for watching our video and hope to see you again in next videos. Do not forget to see other videos in our channel. With my best wishes. Dr. Artef Ahmed. My best wishes.